ends Retina for the morning. So our first keynote speaker is Dr. Guillermo Rocha. He's originally from Mexico City, where he's obtained his medical degree, followed by his ophthalmology residency at McGill University. In addition, he went on to complete a research fellowship in microvascular surgery, as well as subspecialty training in ocular immunology and inflammation and cornea and external diseases. If that wasn't enough schooling, he recently completed his Physician CAO executive program at the Kellogg School of Management. He is currently the president of COS, and amongst his numerous accolades, in 2015, he was recognized as one of the 10 most successful Mexicans in Canada. This was followed by an award of one of the 10 most influential Hispanic Canadians. Dr. Rocha currently resides in Brandon, Manitoba, where he has a busy anterior segment and cornea practice. Dr. Rocha is a big advocate for swimming as a means of exercise, relaxation, and meditation. He also enjoys playing the piano and traveling, especially cycling trips. But the key to Dr. Rocha's heart is none other than delicious chocolate. Without further ado, how to be an innovator, Dr. Guillermo Rocha.
Ever since I was a little kid, I've been totally fascinated by time. Timekeeping, time travel, time machines, and of course, watches. I guess growing up in Mexico City, I learned a lot about time management with its traffic and chaos and 20 million people, just always trying to make an effort to be on time. In a different childhood, in the infancy of humanity, there was a Greek man who was also fascinated with the timekeeping devices of his era. 2,200 years ago, Eratosthenes, using the rod in a sundial, did something amazing. So if I gave you a rod and asked you to use your brain and harness the power of nature, would you be able to measure and calculate the circumference of the Earth? Eratosthenes gave it a try. So he observed that in the city of Syene in ancient Egypt, during the summer solstice, there was no shadow cast on the sundial rod. However, 843 kilometers north in Alexandria, the shadow that was cast had a displacement of 7 degrees. So 7 degrees is 1/50th of a 360-degree circumference. 50 times the distance between the two cities gave him a number of 42,150 kilometers, converted to today's units. Do you think he was right? Well, of course he was wrong, but he was wrong by 5%. 5% in the year 250 BC, he was able to come up with such an accurate calculation using simply his brain, the power of nature, and the rod in a sundial. So what does this have to do with ophthalmology? Well, Eratosthenes was an interesting guy. He had many layers. He was a librarian, but he also observed what happened in a sundial when probably others simply looked or maybe even shielded their eyes from the sun. He was an innovator, the type of innovator that appeared throughout history in different ways. And so I am convinced that in order to have innovation, there has to be time, and time is directly linked to that innovation in the devices we use, in the technology we develop, in the expansion of knowledge. I'm also convinced that, that the more we gain an understanding of the intricacies of the timepieces that are developed through history, the better we will understand how surgical innovation works. So in the next few minutes, what I'd like to do is link aspects of disruptive innovation with those of time in the context of my specialty, endothelial keratoplasty. So by now, maybe some of you are thinking, am I an innovator? Do I have what it takes? Is it in my DNA? So I'll give you two at this point. Every innovator questions, so you're on the right track. And every innovator observes, just like Eratosthenes did. Now there is someone who should have looked at Eratosthenes' notes, and that was Columbus. But when he set out on his trip with the 3 caravels, La Niña, La Pinta, and La Santa Maria in 1492, I would say he was lucky. He was very lucky. He didn't have all the instrumentation. Marine chronometers linked to Greenwich would not be in use until 2 centuries later, and he literally missed the boat by 2/3 of the distance. Regardless, he was gutsy. he needed to find a new sea trading route, and he made history because he had another attribute of innovators, which is the primal hunger for the chase, an inner drive. In ophthalmology, when Edward Zerm in 1905 performed the first successful corneal transplants, he also had the right idea, that inner drive to excel, and also the right rod, the circular corneal trephine, previously devised by von Hippel. So he took 2 corneas from a living donor, transplanted them into bilaterally chemically injured eyes, and he was lucky. He was very lucky. He didn't have all the instruments, just like Columbus. In fact, it would be another 50 years before the use of operating microscopes, fine sutures, as well as a better understanding of endothelial cell physiology would come. But one of the corneas survived for 3 years. So though he was successful, his success really rode on the coattails of his predecessors, who had devised instrumentation and who also experimented. So in order to have innovation, there has to be experimentation. We have to have trial and error. There has to be a time allowed for ideas to grow and evolve and thrive. And there has to be, we have to have an inner perpetual motion to achieve that. So talking about motion and movement, in watches, standard movement refers to the basic aspect of showing hours and minutes. In watchmaking, the term complications is actually a good thing, and it refers to the unique features that add to a watch's character. And so over the years, there have been complications like timing complications where we show date, chronometer. There are astronomical complications when we display the phases of the moon. And then there's the queen of complications. The queen of complications is the tourbillon. It's a tiny magical carriage that regulates the height of the watch, and it was designed to compensate for the Earth's gravitational pull. It is only, I mean, we can marvel ourselves at all the layers of intricate engineering within a watch, and it is only when we look at the cornea in terms of a similar way, in terms of the 6 layers of the cornea, that we can aspire to treat it in a safer and more predictable way. One of my patients had bilateral full thickness grafts, 20/20 vision, a fluke accident happened, busted both eyes, both corneas, ended up bilaterally blind around age 45. So why is it that for a disease like Fuchs that we need to transplant the whole thickness cornea when the disease is localized to the inner layer? How can we make the cornea more shock resistant, like a watch? How can we minimize issues like high astigmatism, suture abscesses, or wound dehiscence? So my cornea fellowship mentor used to say, find a need and fill it. Necessity. Necessity is another aspect of innovation. In the 1990s, Gerrit Mellis from Rotterdam had the same question, and he also had the right rod, the reverse Sinskey hook. So for the first time in history, we were asked to do something that was previously verboten. Grab the instrument, push it against the endothelium, score it, strip it, and then transplant and by sort of harnessing the power of the endothelial pump, transplant posterior stroma, decimus membrane, and endothelium in a 100 micron lenticule. A magical carriage, basically, for the transplant. And with that simple concept, DSEC was born. So how does the graft stay in place? The surgeon simply puts an air bubble in trying to contravene other forces in the same way that the tourbillon in a watch contravenes the Earth's gravitational pull. And just like a watch has tiny jewels that minimize friction in its mechanism, the endothelial cells are priceless. They're priceless. So if engineering can do it, nature, of course, can too. I think the act of engaging the endothelium in such a way, yeah, it might have been a rod, but the reality is it became a lightning rod for what was to come. The DSEC lenticule became thinner and ultra-thin with automated donor preparation. And the driver for these innovations was a safer and more predictable transplant, less risk of wound dehiscence, less risk of rejection, and a shorter surgical time and a shorter recovery time. So picture this, in a way, all of a sudden DSEC has this capacity to compress time. I remember the first time I saw my first successful endothelial transplant, and I was in awe. It was an age of discovery for me. Discovery is not individualistic. The last few years have been a whirlwind of innovation for endothelial keratoplasty. Through observation, questioning, and experimentation, the DSEC graft has been thinned to Decimus membrane and endothelium alone, and the tissue scroll can be visualized with trypan blue, and with that, DMEC was born. Then somebody said, well, why do we use the whole thing? Just use half of it, and hemi-DMEC came up. And others said, why do we use a graft? Let's just not use a graft. Can you imagine that? Not using a graft in corneal transplantation. Well, a better understanding of endothelial cell physiology in Fuchs dystrophy and pseudophakic bullous keratopathy has paved the way to understand endothelial cell regeneration using ROCK inhibitor eye drops that promote cell migration, proliferation, and apoptosis, combined with Decimus membrane without endothelial keratoplasty techniques. This virtuous cycle of ideas and exchanges exemplifies another aspect of innovative thinking, networking, just like we do here. Keep in mind that all of these advances have brewed not in the context of advanced or expensive technological advances or developments, but rather within the confines of the human mind, using existing instrumentation and the interaction of the tissue's biological properties. In essence, we're allowing nature to teach us what it can do. Discovery is pluralistic, and this leads me to the last aspect of disruptive innovation, association, putting it all together. Imagine all that history, all those pieces, all those escapement mechanisms into the tiny case of a watch to give us something marvelous. This is what happens in corneal transplantation when we take all the history, bring all that knowledge from the past, we bring the constant interaction with colleagues, ideas, and industry in the present to give us that next innovation. So if you're as excited as I am, you might be thinking, well, is this it for corneal transplantation? Are we there yet? What is that next rod? And I've got a surprise for you. I actually have a sample here. It is an amazing instrument. It's a very interesting device, and you have used it since your first day in ophthalmology. It's the 26-gauge cannula. Kinoshita from Japan has recently reported on the ultimate endothelial transplant. Go through a 1.6 millimeter paracentesis, strip the diseased endothelium, take ROCK inhibitor cultured corneal endothelial cells, and inject them into the anterior chamber with a 26-gauge cannula. Have the patient face down, just like the retina guys, and then have them come up 3 hours later, and the magic begins. The corneas begin to clear. So do you have it in you to be an innovator? Do you have that ticking mechanism within you? Think of the simplicity of Eratosthenes with his robe and his sandals, analyzing a shadow on the sand. Think of the disruptive genius of Melis with DSEC and DMEC. And think of the gift we're getting from the future through the work of Kinoshita. If you can challenge the status quo, if you can see things beyond what we all see in a regular basis, if you're willing to take risks to solve a specific issue and fail and try again, and if you're willing to accept past history, embrace present collaboration, and dream of a clear and elevating goal, then I believe it is in you to be an innovator. So use your brain, choose the type of power of nature that you would like to harness, and find that rod, that instrument, that device that will change your patient's surgery and benefit our patients as a whole. That idea that will set the stage for the next round of innovations. Thank you.
Thank you very much.